Yes. Yeah. So, hey, Dr. Mukherjee, how are you? Thank you for joining. Hey, Dr. Basu, thank you. Thank you for joining.
Hi,
Appreciate it.
hi,
So,
hi,
hey,
Dr. Mukherjee. It
Vishwa.
must be good morning for you.
Yes, sir. It's a good morning here. Uh, subject here, sir. Uh, yes. And hey, Vishwa from Vishwas is representing. He's a founder and owner of Zerti Pharma. Thank you, Vishwas, for joining as well, and all support.
Thank you so much.
Yes. So, and we have Salma Morsi as well. And Salma is a physician from Egypt, and now she's in Birmingham. So she'll be leading all of the educational activities. And we intend to do this GI uh, every month until Dr. Mukherjee just kicks us out, or just abandon us. And we plan to do other subspecialty as well, depending upon the availability of the other physicians. Yes. Thank you, Dr. Shah. Yes. Uh, and I will so give you a couple of more minutes before we do the formal introduction and stuff. And hey, uh, looks like one of the panelists, Dr. Saklani, we are just waiting on him. And so, if anybody who is joined for the first time or something like, we record, I just want to make sure everybody's okay with it. We record this presentation because number of people, they're not able to join, number of physicians, they're not able to join. So it's mainly anybody who can join, that's great. But at the same time, with our network of 300 plus oncologists, oncosurgeons, as well as Zoetic Pharma network, we sent it out to all the physicians. At the same time, we also publish on the YouTube channel, and as well as on the Instagram and all the social media things. So basically, it's more of the educational activity. So we share it with everybody. Okay. Just to be respectful with the time, everybody's time, I will just start the formal introduction here, and I will not take much of your time. Number one, thank you, Dr. Mukherjee. Dr. Mukherjee, I contacted just about a month and a half ago. He's very passionate about teaching, and he's a leader, chief of the GI Medical Oncology leader of GI medical oncology at the Baptist Health System in the Miami Cancer Institute, which is one of the leading institute. But at the same time, he does outstanding lot of teaching all over the U.S. And specifically GI. He is a leader and give opinions or more of creating the guidelines for the GI oncology. So we were lucky to have him that. So that's number one. Second, Dr. Manish Kumar, uh, he was one of the first person oncologists I got connected, during my journey in the oncology field when I started launching. And Dr. Manish Kumar, he comes from the army background, and thank you for your services to our country. And he has been in Bangalore and he's been in Solaris. He comes with the vast experience in medical oncology and as well as leading the different oncology related, the endeavors. Dr. Basu, heard a lot from about you. I never met person or uh, online as well. I heard a lot about you through the different my colleagues in the Mumbai. Okay, and he leads a fantastic department in the radiation oncology, and he's been also a fluent teacher in taking care of this patient stuff. I think we are still waiting for Dr. Saklani to join us, but we'll just proceed with this thing, and Vishwa is from the Zoetic Pharma, and he has been helpful to reaching out to as many oncologists, residents, fellows through connectivity. Thank you, Dr. Sarabjit. This is all you. You are muted, Dr. Sarabjit.
I'm sorry. I hope you can hear. So, firstly, I would like to thank you for this opportunity and the kind introduction. It's really great to be among such esteemed colleagues. So, the way I thought about conducting this webinar is through case-based discussions. So, what I would do is I would present different cases and walk you through different hypothetical scenarios, and then I would ask, Dr. Kumar and Dr. Basu, how would you approach this case at institutions? And hopefully, if Dr. Saklan can join us, then we would ask his surgical opinion as well. So let's jump right into the cases. I will start sharing my screen. Please let me know if you have any difficulty. Okay. Are you able to see my screen now? Okay, perfect. So I will go to our very first case. So the purpose of discussing this case is to understand the role of total neoadjuvant therapy in rectal cancer. And the practice, as we know, varies a lot across different institutions. And here we're talking about different countries. So I would be very much curious to learn about how you would approach this case at your institution, and maybe we can both learn from each other. So the first case is that of a 48-year-old male who is very active, no comorbidities. He presents with rectal bleeding. A colonoscopy is performed, and it shows distal rectal adenocarcinoma, 4 centimeter from anal verge. And the biopsy shows moderately differentiated adenocarcinoma. For discussion, let's say this is microsatellite stable. The patient would prefer to avoid permanent colostomy if at all safe oncologically. So maybe we can start with Dr. Basu. What would be your minimum staging workup before discussing treatment?
So require an rectal MR, so an MR with a rectal protocol, because that's also a challenge. Many people come visit us with an MR, but that's not done with a rectal protocol properly. Like they don't set the T1, T2 protocols proper, the angulation. So proper rectal protocol. So a radiologist trained in that would be able to report. And I want all the points in that, because yes, this 48 years should be discussed in today's time and in TNT approach and trying to sphincter, but then we'd want an MR not just to give the T and N, also give the MRH status, the EMVI status, so that which protocol it would fit into, we know the detail. And of course, for a distance screening, probably a CT thorax would suffice if that MR and should be sequential. It's that MR is not suggesting heavy nodal burden or some external iliac node or a T4, then we can skip it and stick to a CT thorax. But a proper rectal staging MR is mandatory. And since biopsy and you mentioned the MSI is stable, and so this should be the basic, and then depending on some other investigation.
Perfect. Dr.
And a CA level, yeah.
CA level, of course, right. Dr. Kumar, do you have any other thoughts or anything else you would like to add?
Yeah, largely I agree. Couple of like additional points which I feel is doing a up at, by the time patient comes to us, they already has got the PET done. But suppose a patient coming to us for the first time, and if I see that it's a mucinous adenocarcinoma, maybe that is the time I may not be very keen in doing PET. In that case, as Dr. Basu said, that a very good MR with a rectal protocol is definitely mandatory, and a CT chest should be good enough. But otherwise, along with MR, I would also like to do a PET scan. And in terms of tumor marker, obviously we get CEA done, but we also try to do a CA 19.9 these days, because we have seen that many cases CA 19.9 is also raised, and these are the cases who don't do very well. Like, it's a kind of prognostic marker, I would say. So that's in addition. So more or less, that's what we will like to do before we take the case to NDT and discuss it.
Sure, great. So, at our institution, we would approach this case very similarly. PET is still considered on a case-by-case basis. I wouldn't say that it is routine for everybody yet here, but at least a CT thorax. Actually, in addition to rectal MRI, most of the time patients will also get a CT chest, abdomen, and pelvis with contrast, and in some cases PET. So I will go to the next slide. So the MRI pelvis, or here it was done per rectal protocol, showed a 3B in one disease, and there was question about threatened mesorectal fascia. The radiologist couldn't say if it was involved or not. They said it was close, but not grossly involved. EMVI was present, no distant metastasis, and CA was slightly elevated at 6.8. So the question is, what's next? Would you recommend a TNT approach, or would you recommend a standard chemoradiation? So again, I would start with Dr. Basu.
For a 48-year-old and a T3B N1 wanting to preserve sphincter, we should recommend TNT. Knowing from all the recent TNT, if we're not doing, then we are increasing the chance of distendment. So I think for a standard chemotherapy and TME and take a call of adjuvant is not the right approach. We are increasing chance of distendments for that patient. And somebody wanting to preserve sphincter. Now, in TNT, next debate always remains like, we go a Prodigy way, we go an Opera way. That's a debate. That's both has their pros and cons. So let's see what Dr. Manish has to say then.
Sure.
Regarding TNT, I would say that initially when we started discussing about TNT, maybe around 5 years back, at that time we found it interesting. And as a matter of coincidence, even today people find it very interesting, but somehow still not got into routine general practice, despite the fact that we very much agree with the idea, and we still case-to-case basis. Like in this case, young male, definitely sphincter preservation would be a goal. So we would definitely discuss TNT for this case, and we would like to be aggressive upon the PS of the patient, which seems to be okay. And there's no strong reason for not trying TNT here. It's an option. If it's all other parameters are met, then definitely I would like to try TNT in this case. And that's what we do also in our centers. We try. Otherwise, obviously, the other approach is also equally decent, I would say, because as such, there's no OS benefit to one different. But yes, this gives us better outcome chances. So I'll prefer TNT.
Now, regarding TNT, I would like to get your thoughts on one versus other. Like, should we start with chemoradiation followed by consolidation chemo, or induction chemo followed by chemo RT? And I think Dr. Saklani has also joined us. So thank you for joining and welcome.
I think as a medical oncologist, I would always like to give chemo first. Having said that, no difference between either of the way, whether you give chemo first followed by CRT or CRT first followed by chemo. But conventionally, we have been giving chemo first, not backed by very solid reason that's how it's better. So it's anybody's choice, but I prefer to give chemo first followed by CRT in case I'm choosing TNT.
Sure. So I just saw that Dr. Saklani has joined us. Dr. Saklani, welcome. And just to give a brief update about what we are discussing we're discussing about a case of a 48-year-old gentleman, robust performance status, no major comorbidities, distal rectal cancer, about 4 centimeters from anal pars. He is very much inclined to preserve his bowel function and avoid a permanent colostomy if possible, or if at all considered oncologically safe.
Sure.
So we were basically, discussing that, we did a pelvic MRI and it showed T3B-N1 disease, threatened mesorectal fascia, EMBI was present. So what would be the role for TNT here? So we were discussing, different approaches, and would be very much curious to know what you think and how would you approach this case at your institution.
It's levator and sphincters are free as well, is it?
Say for this case, they are free, yes.
Okay. I think it depends on the intention of treatment. So I think probably this is a high risk cancer with EMBA positive and MRF. So maybe you may not be thinking of organ preservation, but I think TNT is quite standard. But depending on how things are, I think you can have chemo first, the Prodigy 23, or you can have CTRT and consolidation approach. I think the tumors in India are slightly more aggressive. 6 cycles of chemo sometimes intensive is too much for them. So, so what we would do is normally give you could have both the options open, and then depends on what radiotherapy you want to give. You want to give SCRT or not. If I think I'm going to preserve the sphincter for this one, in the future, I would not give short course RT because for intersphincteric resection, it's not a very good thing. So then I would, and with EMBI, while there is no solid data to show giving chemo will prevent metastatic, but people with EMBI have a distance metastasis slightly. So I would probably give 2 cycles of chemo, then TRT, and followed by another 2 cycles of chemo. If the patient has lateral nodes, however, I've seen the last couple of cases, with just chemo alone, they tend to progress. And one actually has gone into the sacrum and the other one has become distant. So if you don't have lateral pelvic nodes, so I would have a sandwich regimen, 4 cycles of chemo before. You could do an MRI before. So if they become MRF low risk, and if you're planning to operate, then you can do upfront also, like the FOVAC trial sort of thing, because there's no difference of chemo versus CTRT. And then CTRT and 2 cycles of chemo. But if lateral pelvic node, then I would go for CTRT and then consolidation chemo 4 cycles like OPRA. So, but difficult. So I think a lot of things, organ preservation or not, I'm going to do sphincter preservation. So I'm inclined more towards CTRT if I'm going to do sphincter preservation. And if lateral nodes, then radiation first.
So actually, that's also our preferred approach here. We usually start with, for cases like this, long course radiation followed by chemotherapy rather than going the induction way. Although, I understand that there's a lot of variability in practice across, different institutions. Now, obviously, I think we all agree that for cases like this, we would prefer a short course chemoradiation. But question for you, Dr. Basu, when would you consider short course radiation for rectal cancer?
So we had a lot of enthusiasm with Rapido at one point about 2-3 years back. It seemed to reduce, and Avnish was very well working in the same city. He was instrumental in TMH on that. In today's time now, coming back, we have shifted again do boost of lateral pelvic node. In short course today's time, I would say probably a geriatric, not so fit cohort and more advanced disease where they will not be for intensive chemo. So probably best do short course, reduce the local symptoms and then a tailored chemo or not for so if and then goes maybe to the mid rectum where it's not close to sphincter like sir rightly said long term if my goal is TNT with sphincter preservation then of course short is not a good idea having lot of LARs later on but a mid with properly an MR noted and functionally assessed sphincters as spared then probably short course is not bad.
Sure.
There's a,
I would add
oh,
another. Sorry, go ahead.
there's a lot of short course for oligometastasis.
Yes, sir. Yeah, I was skipping the ones in this. Yes, for oligomets, definitely. Yes.
I would like to add another, scenario. I'm pretty sure that you have seen these. Sometimes we see patients coming from other cities, and they have limited resources, and they often tell us that I really can't stay for that long. We also see a lot of international patients, and I'm sure you do that too in Mumbai. And sometimes they would say that, what if I could just stay here for a limited amount of time, and then go back and then maybe get chemo locally. We have discussed short course radiation for some of those patients as well. So we'll proceed to the next slide. So the patient receives chemo-RT and the patient starts with long course chemo radiation by consolidation chemotherapy. And after 10 weeks after TAT completion, they have a DRE which shows minimal irregularity. Endoscopy shows flat white scar, but no ulcer. The biopsy does not show any active malignancy. MRI shows marked regression, no obvious residual mass, and the nodes are not visible at this point. So what's next? And I would probably start with Dr. Saklani. Would you consider this as a complete clinical response, and what would be your next step? I think you're muted, sir.
So I think we would normally discuss is that you board see the scans before and after, and if it looks like triple assessment shows clinical complete response, then you can discuss with the option of wait and watch. Wait and watch, these are slightly high risk features. So normally, if you give wait and watch, the chances of local regrowth are 20%, and the chances of salvage are 90%, and with 10% distant meds. With slight high risk features, EMBI and MRF positive, the chances of regrowth slightly on the higher side, 30 to 40. So we explain this to them, and if they want to go for wait and watch, you can do that. I think I've recently seen a paper where even for high risk patients from the Swedish cohort, when they've done wait and watch, the local regrowth was still okay. But I just exercise caution and tell them the options of LAR for going for surgery or a local regrowth with a salvage rate for this. And if they accept it, then I would think what would be a policy in US actually. I think wait and watch, I think, isn't it? Yeah.
Right. So I would say that at our institution, we've shifted more towards, wait and watch for a lot of these patients where we, see clinical response. I think that what is important is we try to assess the compliance of these patients. If we're doing a wait and watch approach, whether we are very confident that this patient will follow through their surveillance exams, including sigmoidoscopies, DREs, and MRIs at certain intervals. Sometimes if we feel that the patient may not follow through, or the patient is coming from distance, then we tend to offer surgery more aggressively for those patients. I don't know, Dr. Manish or Dr. Batsu, if you would like to add anything.
Largely agree. There's also true that these days we are moving towards an era of de-escalation wherever it's possible. So if the patient is lucky enough and we get near, CCR or CCR, then definitely having a discussion with the patient makes sense. But if I see that there is a strong chance of sphincter preservation based on MRI at that point of time, then obviously I'll try to push the patient towards surgery. And secondly, I'll definitely discuss while talking about active surveillance that active surveillance is pretty hectic, like it's not easy, right? So at least for first 2 years. So after explaining them everything in detail, if they still want to go over with active surveillance, and the response is good. Nowadays, this is an option, so that can be considered.
Yeah, I agree. So the compliance is the biggest risk in this because this is not, this has high risk features. So more of a reason. So suppose that had it been like a T3A N0 and no other features, that definitely is a better cohort for wet and watch, and know the risk could be low. But this with N plus with the MVI has risk local as well as distant. So for a patient who's not that compliant, still maybe proceed to TME is safer for long term, say oncological safe outcomes. And of course, on an active working age, wanting to preserve because that changes a big quality of life. So then they have to understand what they have to do in strict surveillance. And I'm sure Sir has faced it. It's very common here also for 3 to 6 months, people remain quite enthusiastic of the fact. And the moment, and we all have seen it, then they lose that track and then they come back with non-salvageable surgery scenario and with meds or maybe just local or local distant boards.
So,
Let me ask,
sure.
gentleman was 75, had bypass, but looks pretty fit. And this lesion was 8 centimeters, and somehow he's got a complete response now. So, would you say watch or would you offer TME?
So, I would say that here, much of these decisions are very much, patient driven. So patients basically choose what they want to do. We basically present them with options. But, in such cases, historically, what we have done at our institution is for, elderly gentlemen, if we are very, confident that they would follow through, we would mostly offer them wait and watch rather than offering them TME. But it's, as I said, that it is very much patient driven here, and surgeons or physicians just present them with options. So I will actually move to the next slide. So this particular patient was offered a wait and watch with strict surveillance. So at 9 months, surveillance endoscopy shows a small nodular regrowth at the scar, but no distant metastasis on CT scan. So what should be our salvage approach? And I would go to Dr. Saklani again. Would you consider a salvage TME? Any role for, local excision? Would you like to give them some chemo first to see how the biology behaves, or any role for radiation? But I will come to Dr. Basu maybe at the last. So I'll start with Dr. Saklani. I'll go to Dr. Manish, and then finally I'll go to Dr. Basu.
But obviously, you look on MRI, what is this local state, whether it is T1 or T2, the size of the lesion. And if it's a very small nodule regrowth, means the option of TEO procedure versus TME is there. But I think what I normally tell them, actually, most people for regrowth would prefer a TME, but there is a data from the French group which has come, which is even in regrowth, you can do local excision. But how a consult if I do local excision in this patient? This patient is, you can do sphincter saving surgery. We do about intersphincteric resection, we do 50 year or so. So if I offer TME for this patient and his sphincter was free, then I can save his sphincter. But if I do a local excision and then there are features, and then he may end up with an APR. So again, you take patient choice, but mostly for local regrowth, we prefer TME. I think our confidence is doing local excision for TEO is not that great. And then if they come back with a bad regrowth, it's a bit difficult, but it has been done and can be done.
Sure. Dr. Manish, would you consider, giving them additional chemo points?
Re-radiation, of course, this is Dr. Basu's field, but I would say that re-radiation and systemic therapy is not something which I would consider. Definitely option A and B would be discussed. Giving this case scenario, if the person decides to take active surveillance within a high-risk disease, I'm sure he prefer having a local excision. But between these two, one has to discuss what they prefer. But preferably, if I have to decide. I'll still suggest TME here if it's possible. But then it depends what patient wants.
Okay. Dr. Basu, this patient, in particular, received a long course chemoradiation. But if he had received short course radiation in the beginning, would you consider re-irradiation to help with the, maybe salvage the sphincter?
Not really. I think the surgical options, because we have to see the overall disease also. It's not rectal re-radiation itself is quite toxic, if I say so. And this is not and it's just not about. It's just not a local recurrence, and we try to do some sort of local therapy, be it surgery or radiation. It has a rating of the disease eventually failing distally and a lot of other QL issues. So no, it's between A and B, as how strongly the patient at that point wants still to retain the sphincter or just to get rid of everything as surgery.
Great. So actually, this patient was offered a salvage TME, and the patient remained cancer-free at 3 years. So that was the option that was chosen here. So, spent quite a bit of time on our first case. We still have to go through 2 cases. So I'll try to spend maybe 15 minutes each on the next 2 cases. So our case number 2, we actually oligometastatic liver-only colorectal cancer. So this is a 62-year-old female patient, decent performance status, newly diagnosed sigmoid colon adenocarcinoma. CT showed 3 liver lesions in segment 4A, 6, and 7. The largest one was 3.2 centimeters. No extrahepatic disease. So again, I would start with Dr. Saklani. Would you consider this resectable or maybe unresectable, but potentially convertible with more chemo? What type of workup would you like to do?
Miss, I would get an Miss. Nowadays, I think our policy is for all status to get MSI status done to see if it for immunotherapy. Right. That we would do. And normally 3 mets or something we would coil the liver lesions. I mean, only single liver met, and we could do synchronous lesion resection as well. The noduling is in the perioperative chemotherapy. There's no difference in overall survival sort of thing. So, but for these 3 mets, I think best would be if it's non-obstructive, we would do 3 or 4 cycles of chemotherapy. They are resectable liver mets, so whether to add biological to this or not is a bit difficult, because I think the last study had not shown any with good outcomes. If you give biological and resectable liver met, then I leave it to the medical oncologist and all. If it was near obstructed or obstructed, then I would get him stented and then still give chemotherapy and see how things go.
Would you consider diversion in some cases?
Diversion could you, but I would prefer stenting actually. So if they can't stent it and you want to do diversion and if they obstructed, then okay, yeah.
Sure. So I'll go to the workup and then I will come to Dr. Manish and Dr. Basu as well. So the patient ended up having an MRI liver, which basically confirmed these 3 lesions. There was one close to the right hepatic vein, but it was potentially, removable. The primary tumor was not obstructive, and it was asymptomatic as well. The molecular profiling showed MSS. The patient was RAS mutant, BRAF wild type. CEA was elevated at 58. So I think, Dr. Saklani has already, mentioned, his preference, but, I would like to see if Dr. Manish or Dr. Basu, you have any other thoughts on how we would approach this case.
Yeah, so, these days, MSI has changed everything. and that is the first thing to do because now we very well understand the perioperative setting, the metastatic setting. There is a very high chance that suppose patient is MSI high and we start with immunotherapy and patient has a complete response. There's a definite case for not doing anything and just observe. I mean, this is also a possibility. And secondly, it also tells us about tumor biology and all. So
just to give you a little bit of heads up, our third case will be MSI high, and we will discuss about perioperative strategies. So
that's fine. That's fine. So the point is, in this case, I would like to definitely do a MSI initially to begin with, and then suppose MSI stable comes. Then
so
I
this
will,
patient, it was MSI stable.
yeah, so MSI stable. Then I would like to definitely consider the conversion therapy route. And since it's BRA, say I think
RAS mutant, but
mutant,
BRAF
yeah.
wild type.
So when it's left-sided tumor, I would like to give 4 cycles of chemotherapy, and maybe first 2 I would like to give along with BEV, and then last 2 and every 2 monthly assessment. So on third or fourth cycle, I would like to omit BEV and see if the response is good. Then maybe I'll try to discuss it with the surgeon if patient can be operated, and then subsequently followed by that adjuvant therapy. So this is how I am going to approach 2 cycles of preferably age. You said is 62, right?
Age is 62, yes.
Yeah, so the patient may not be ideal candidate for triplet therapy, Folfixiri, though that would have been better compared to Folfox. But keeping age in mind, maybe I'll just try to give Folfox with BEV for 2 cycles followed by Folfox alone, and then reassess for a possible surgery.
Sure. Now, Dr. Basu, I would come to you. Would you consider any liver-directed therapy first? Say, SBRT, for example, patient has 3 relatively, small, I wouldn't say small, but relatively small mets. What would be the rule for SBRT in such cases?
See, one is technical, so doing is not a challenge, but then it's a metastatic disease. Though liver CRC is a different entity, so I guess this should go for systemic definitely first. And rightly, as Dr. Saklani said, I know here in TMH because I'm trained from there, so we always do coiling. How it helps, because for liver limited CRCs after the initial systemic, the liver might vanish actually. You don't find anything in the images. So once the primary is taken up, for some reason, if that liver mets is not operable, for some reason, though most of the times I've seen surgeons doing the both, then we'll have a chance of consolidating a local treatment at that point. Else for us also, after the systemic, with the radiological CR, come back and do SBRT is very cherubic. Then it's just a blind way of doing. So that coiling remains definitely necessary, but it should be with systemic for sure.
I completely agree. So this patient was actually treated with Folfox. Although for some younger patients, we would prefer Folfoxiri. BEV was not given because, the surgeons felt that they could safely, resect it. So they decided, the medical oncologist decided not to add BEV, but I agree that there could be a role for BEV, definitely, especially when we're trying to shrink them as much as possible. So the CEA went down to 18. The patient had a partial response, and there was no new disease. So the question is, what should we do next? And I would, Dr. Saklani, would you consider resecting the liver first, then primary, or resect both? Will be, more response? And then again, finally, I would come to Dr. Manish and Dr. Basu to see what would be the role for local therapy like ablation or SBRT. Dr. Saklani, I think you're still muted.
I think 4 cycles and the disease is still there. I think you already primed them with chemo. They were resectable before. So we would resect, and it looks like low volume disease. So you can do synchronous resection. For this, we do the liver first approach because we will require porta clamping at some point, and if you do colonic resection we would do the liver first section, synchronous section with the liver done at the same time first, and that will be followed by sigmoid colectomy.
Perfect. Dr. Manish, do you have anything else to add?
No, I perfectly agree with sir that it's a right time to operate. And as it is to begin with, the size is also not very big, and the number also, I think, 3 or less. So the right time to take up the patient for surgery. So I agree with that.
And Dr. Basu, maybe not as relevant for this case, but I would like to ask your opinion about when would you consider local therapy like ablation or SBRT over surgery for oligometastatic disease? So small volume mets, say 2 to 3 mets, each less than an inch. When would you consider ablation or SBRT? Or when would that come at your tumor board discussion?
So if it's a liver limited CRC after the good initial systemic therapy, I would say a very practical, pragmatic answer. It comes to us only when that local therapy, the local surgical approach is not feasible. And most of the time, as sir rightly said, it's most of the time liver followed by the primary. If for some reason, and that's can be anything, that patient has deteriorated medically, some comorbidities or some changes in liver function or something else after the chemo, which is not deeming fit to undergo, that's when that probably the local ablation in form of SBRT, for me at least, would come up. And one maybe a bit more higher age, not this age, like approaching mid 70, closer to 80s, then their chemo itself would be a challenge. So probably then it's like the geriatric age group, not a bad approach. They might not be able to tolerate both the surgery. So surgery for the primary non-invasive way of doing SBRT to that, and some tailored chemo in that probably. Or maybe after initial, not in this case, after initial successful treatment, if later develops an oligoprogressive liver, then definitely SBRT is a safer option.
Sure. Now, Dr. Saklani, the next question is for you. So for staged resection, I'm curious, what is your interval between liver resection and primary resection?
Normally, I think they will do with their operation, and we would give it about 4 to 6 weeks. And suppose the patient is taking some time, it depends on what morbidity they have after liver. Most of them won't have, but if they have any morbidity and they are frail, then you might operate after 6 to 8 weeks if they're too early. But if they're going to wait for that time, then we can also give another couple of cycles of chemo in between. But normally 4 weeks is okay. I think normally they can take a subpost and doesn't interfere with our incision.
Great. And I, would completely agree with everything that has been said. At our institution, we try to limit the preoperative chemo for those patients that have potentially resectable liver disease, as we know that oxaliplatin and irinotecan, they can both induce, liver damage through different mechanisms, of course, sinusoidal injury versus steatohepatitis. But we try to limit the number of preoperative chemo. We present them early and we present them frequently after every 2 months or so to see if they have become resectable, even if they were initially unresectable. And then, we try to limit to 6 cycles maximum before starting, before reconsidering surgery, if they're going to be surgery candidates. Now, for some patients, if conversion is not possible, then of course, we continue with biologics. But for those that are initially considered resectable, we take a similar approach, try to limit the chemo, and then we typically go for staged resection, liver first, followed by the primary. So this patient, underwent that. So we chose option A for this patient. Now, my next question will be for Dr. Manish. After both are out and the patient has well from both surgeries. What would be your approach regarding chemotherapy? How long? First, whether you would offer it to everybody or whether there's a discussion. And secondly, if you offer chemotherapy, typically how long would you offer it for?
Yeah, before I answer that, do I have the permission to ask a question from Dr. Saklani? That in such cases, when we do conversion therapy and the patient is operated simultaneous or maybe staged, what are the percentage complication rate? Or I mean, like in terms of say explaining to the patient, because at times it does happen that the patient comes to us and before we send the patient to surgeon, they also tend to discuss with us and theoretically we can say, okay, this is the percentage complication rate. But in perspective, the real world experience, I understand what is the complication rate in these surgery.
And typically, if you look at it, it depends on the type of resection. So if you're doing sigmoid and for us, traditionally it is said liver resection has less morbidity. So you do liver first. Whereas for if you do rectum and colon, they are risk of anastomotic leaks and all things. For us, sigmoid resection, actually the morbidity is less, so we are okay with it. But our liver surgeon, the Mahesh Goel was there, he was also pretty good. So if you're not planning an extended resection or liver resection, if you're doing standard, this looks like only parenchymal-sparing resections only. So there would not be much of a morbidity.
Okay.
For these limits, even do minimal invasive resections sort of thing.
Okay. Yes.
Section in bilateral vesicles and stuff. So these people are going to have morbidity and stuff. So definitely because the morbidity of liver is less than that of liver.
Yeah. So this makes sense with respect to the question that also you asked, because traditionally I would like to complete 6 months of therapy. So if I have given 4 cycles of Folfox earlier, then I would like to give another 8 cycles. Suppose if I've given Kevin, then maybe, it all depends. I'd like to complete 6 months of therapy in total. So depending upon the number of cycles I have to give, either 4 I've given earlier or 6 I've given earlier, preferably 4, then I'll give like 8 more cycles to complete that 6 months of therapy. I would not like to change the regime. I would continue with the same regime. It is unlikely that the patient condition would have improved after surgery to, change the doublet to a triplet. So continuing with the same chemo to complete 6 months is something which I would like to do.
Right. So, yeah, sorry, go ahead.
You just gave chemo radiation to the first patient and he's got very good in the primary and he develops a solitary liver met. What would you do?
So for solitary liver met, depending on, of course, the location and the size of the tumor, the first thing we would like to ask, is how long has it been? Like, is the biology really aggressive or, has it been, say, a year after then the patient developed, solitary liver mets, right? But
you gave TNT when you reassess him again, found
okay.
the liver. So now primary has good response and now you have a solitary liver met. This is a real situation.
Right.
Operate, but a lot of people suggested this is progression on TNT, so have more chemo second line. So I don't know what we.
Right. So actually, that's a very interesting question that you asked. So we encountered actually a very similar case. And sometimes what we, realize is that sometimes these metastatic lesions were probably there and maybe we didn't catch it before. So, we have to really understand if this is true progression on TNT versus this is something we didn't see. But, assuming that this is a true progression at TNT, I think that kind of tells me that, this is not probably going to be very chemosensitive anyways, because, sometimes with TNT, we even use the bridge regimen, the folfoxy. So if the patient is, responding, not responding after that, then presenting with, newly developed mets, what are the chances that my salvage chemo regimens will control it adequately? So we encountered a similar case and we actually went ahead with a resection of the, liver met as well as a T. So that's how we approached the case.
We had a similar case and he refused this. So he went to Canada and had the thing. I hope he's come to your institute. I hope it's not the same patient.
Well, very possible. So just wanted to follow up and let you know that this particular that we spoke about, was offered adjuvant chemo and developed neuropathy after a couple more cycles. So just finished with 5-FU alone, but completed 6 months of treatment. So in the sake of time, I will move to our very last case. And here we will briefly discuss the role of immunotherapy, which is still evolving. So this is our case. A 55-year-old male patient, right-sided colon cancer, presented with iron deficiency anemia and had a colonoscopy, which showed an ascending colon mass. Biopsy revealed adenocarcinoma. Immunohistochemistry showed loss of MLH1 and PMS2. The staging CT revealed T3/T4 tumor, suspected lymph nodes, but no distant metastatic disease. Symptomatically, the patient didn't present with any symptoms of obstruction. They were able to pass the scope without any problems. And we, routinely, reflexly, check BRAF V600E mutation. It was also pending. Patient was also referred for, germline genetic testing to see whether this is potentially, Lynch syndrome or HNPCC. And that was also pending that time. So what's next? Should we offer neoadjuvant therapy? Should we offer upfront colectomy, or anybody in favor of neoadjuvant chemo? So again, I would start with Dr. Saklani, and then we'll go to Dr. Manish and Dr. Basu.
I think with MSI high status, if the node is there, even if there are nodes there, it will just be immune response itself. So I think the Foxtrot had shown that if you're MSI high, giving neoadjuvant chemo didn't benefit these patients anyway. So then you think about this, whether this is resectable or sometimes if they're quite resectable, you could resect as well, or you could give 2 cycles of immunotherapy. You could have ipilimumab and a combination of nivolumab. And that's only 2 cycles, and then you can reassess, operate on them. But it improves the response to nodes and downstaging. So there is data for this. 67% will have complete response to this. But there is no data of improved survival by neoadjuvant immuno-oncology. So you just start the patient if it is resectable. Data long-term survival is not there. So if you want, you can give it, or you could go ahead with surgery. So that's my take on it. So I just leave it on this. If he wants to have 2 cycles of immunotherapy, 1 cycle of epi and then ipilimumab combination, then you can, whatever the data is there. But if it is resectable, even if it is MSI high, not that locally advanced, I would go ahead. So I tell them downstages, but so far no data on survival.
Sure. Dr. Manish, when it comes to choosing the neoadjuvant immunotherapy regimen, how do you choose between doublet like Ipi-Nivo versus single agent immunotherapy? Would you, by default, offer doublet to everybody unless they're not eligible? Or would you sometimes consider single agent immunotherapy, particularly given how strong, the dostarlimab data was?
I think, we understand that the combination VP has a better response rate. But I'm not a big fan of CTLA-4 inhibitors. They are highly toxic. I'm repeating it thrice because whenever I have used, patient had a lot of problems, and especially with single agent dostarlimab, now we have good data. So with this kind of setting, one thing I'm very clear, I'm not going to use. I'll definitely tell the patient, and I understand that neoadjuvant chemotherapy is not going to be very effective given MSI high status. Immunotherapy definitely makes a sense, and knowing the fact that it's only for a limited time, and this is also a problem that we don't know how long to give and what all, but at least for a short duration immunotherapy, single agent, which is cost effective also for the patient, and with very much less side effect compared to a combination. I would prefer single agent immunotherapy certainly uh, in a perioperative setting. Regarding OS data, yes, I mean it's evolving. We all understand, and if you look at dostarlimab data, it's pretty impressive. So I think immunotherapy does make a sense for me. Single agent, yeah.
Now, maybe we're just, taking a tour to come to, Dr. Basu. This is a colon cancer patient, but, for rectal cancer, say hi. Are you offering radiation to anybody, or are you saying that just go to your medical oncologist and get immunotherapy?
Fortunately, that cohort is low in India. As we compare to Western population, that cohort is really low. So, uh, frankly, we hardly find, to be honest, MSI high rectal. Uh, as the West is so pessimistic after all the data, we hardly find. I think Sakal would agree. We hardly see rectal MSI high somehow.
Right. That's even rare in our patient population too. With 5% of, of patients. Sorry, Dr. Abnish, you are
It's
muted, I
3%.
think.
So, but I have to agree. We looked at a little. So 3% of these are MSI high, but like the dostarlimab study with 100% having complete response, with I have to say we haven't said that great results as well. Okay, because some of them have back. So eventually, if you're not using dostarlimab, you're looking something else. And now you have this generic immunotherapy which have been used, and I tried it on someone who's had TNT. So all the data for dostarlimab is for limited disease. They were not very bulky disease. They were not sickness. They did not have PDAC, and they were after TNT. So what happens is most of the time people have TNT and they come to you and you get their MSI diagnosis, MSI high. They said, okay, let's have immunotherapy. And then there's no one who's looked after this. The effect of immunotherapy after TNT is not that great. I've operated quite a few, and most of these are mucinous tumors. So MSI high mucinous tumors, radiologically, there won't be any change at all. So a bit difficult, but we do MSI and put it there. We give this, but we have to.
Now that brings me to another question. So if somebody like this patient received EP-Nivo and you saw a phenomenal response on their subsequent imaging, not rectal cancer, I'm talking about colon cancer, which is in general, ascending colon cancer should be easily resectable. Would anyone feel comfortable doing a wait and watch approach for somebody who is resectable? Maybe I would start with Dr. Saklani.
I think wait and watch we only do for anything that a finger pass that there. So a bit difficult. So what I would do is we have to operate on this one. Probably, I think after immunotherapy, it causes a lot of fibrosis. So if I'm going to operate on this, I would prefer a robotic approach for a right colectomy where you have controlled dissection sort of thing. So yeah, okay. So definitely we have to operate. Yeah.
Sure. So just to close the loop, the patient did undergo an operation which reported near PCR. So as we know from the NICHE 2 study, the major PAT-CR rates were over 95%. The nodes were negative too. So I think my last question would be for Dr. Manish. Would you consider continuing single agent immunotherapy? Would you take the atomic approach, given that the patient was initially, node positive? Would you just surveillance, or would you consider a ctDNA guided strategy and make your decision based on if the ctDNA positive?
I would start with the lower one. The ctDNA guided strategy is very, very, very interesting, but so far we are not yet following it. Regarding adjuvant immunotherapy, again, so far we need to mature a little bit on that. So I would like to continue this patient on adjuvant Folfox to complete the therapy. No adjuvant therapy surveillance. I mean, in this kind of colon where the patient had such a good response, operated, I would definitely try to discourage and put the patient towards adjuvant chemotherapy with Folfox.
Thank you all. I know that we finished our 1 hour time slot, and I want to be respectful of everyone's time. If anyone has any final thoughts or any final questions, maybe this would be a good time to talk about that.
I'm thankful to all of you guys, specifically Dr. Saklani, Dr. Manish, Dr. Basu, for your valuable opinion. I know it's could be so busy that in India there is no perfect time, right? But spending the time from your busy schedule and helping us. Of course, Dr. Sarabjit, fantastic session for leading, and he is going to lead this GI webinars every month, and would love to have suggestions and would love to have you guys again for contributing towards this. That's one thing. I have Dr. Salma here. She's an oncologist. She's a MD medicine from Egypt, and she's working. She's our educational director, so she will be better in coordinating this than me as an orthopedic surgeon. You know how good or bad we could be. And the last, Vishwesh, Zoetic Pharma, if you would like to say a couple of words, because Vishwesh has been instrumental reaching out to our next generation of oncologists and current generation, the resident fellows and the current oncologists and oncosurgeons.
Thank you so much, Dr. Ashley, for the introduction, and thank you so much to the entire panel. Dr. Saklani, Dr. Manish Kumar, and Dr. Basu for your time and valuable insights. And thank you so much, Dr. Sarabjit, for your insightful, these 3 cases which have been useful. And we are at Zoetic, we are trying to, create and foster this community of, young doctors as well. So we have few different initiatives, and here is one of the webinars that is in conjunction with SecOpp team. And we also have our own little newsletter where we feature, interesting cases through the month. So thank you very much for joining in this effort.
Okay.
Thank you,
all.
everyone, for
Appreciate it.
joining. We'll come back next
Thank
month with
you.
another
Thank
webinar.
you.
Thank you.
Thank you, Dr.
Thank
Sarabjit.
you all.
Excellent
Thank you.
contribution. Thank you.
Thank you.